Could a simple infection turn deadly in just minutes? Or could fatigue that won't go away be something much more serious? Blood and what's in it is powerful, and when it malfunctions, the results can be catastrophic. I'm Dr. Jay Rutland, and today on the Health Exchange, we're joined by Dr. Joomee Shim, a clinical assistant professor of medicine at Keck Medicine USC, where she specializes in hematology and oncology. We're taking a closer look at the hidden forces in our bloodstream and the disorders that threaten them. One tiny change in your red blood cells can change your entire life. Let's get into it. Dr. Shim, do you mind if I call you Joomee?
Yeah, that's fine. Call me.
Listen, we were just talking. You got lots of things to say, but tell me about how you got to where you are right now in medicine.
I did a 6-year program. So for medical school, I went to University of Missouri, Kansas City, and I went straight from high school directly to medicine. I don't know if that was the right choice, but
Yeah.
it just became like that. And so I did a 6-year program and I finished. And so during that 6 years, oncology has been a big factor in what I wanted to do. And so like for me, it was very interesting to see your own cells sort of mutate and sort of attack your body. And so for that reason, I think I was sort of very interested in oncology. The big question is, what do you want to specialize in? And so for me, is I was more interested in the immunological, biological agents.
Yeah.
And also, one of the radiation oncology doctors told me that, hey, look, radiation, you have to be centered to a big facility. And so medical oncology is you're more flexible in where you want to go. And so, and you can pretty much do medical oncology at a different, anywhere, basically.
So when and again, when we say the word oncology, we're talking about cancer. She's a cancer doctor, right? And so that's what you deal with. But also turns out that, oncologists, they do another fellowship. Usually they do hematology fellowship, right?
Exactly. So
And hematology is like
blood disorders.
Yeah, like red blood cell disorders.
Yeah,
right?
so there's benign hematology, which talks about like anemia, like basic blood disorders, blood clotting issues, platelet issues that you normally see, thrombocytopenia, and those kinds of issues. And then there's a malignant hematology side of it, which is more of like blood-related cancers. And so that's for that reason, that's why they're sort of combined together. Okay.
Right.
And so unfortunately, we do have to do both specialists to sort of get certified in both hematology and oncology. There are fellowship programs that do oncology by itself, but those are more rare. Most of the programs are directed towards hematology and oncology for the reason that a lot of the hematology malignancies are sort of tied in together.
One of my favorite professors at the University of Iowa, his name was Dr. McFarland. And he was from England, and he was like one of the coolest people at the University of Iowa. So when we were on the hem-onc rotation, and he considered himself a hematologist, but we were doing inpatient oncology and hematology, and he would always take us around. And when we went to the lab, he would always like look through the microscope himself and diagnose things, right? He would always just say, okay, Dr. Rutland, let's go to the lab, let's go look in the microscope, do lightning rounds, and we're gonna go. Like I'm just an old-fashioned hematologist. And one of his famous quotes to me, and he would say this all the time because you know how hospitals are, like academic institutions, and Iowa's really no different. There was a lot of policy, and he would like shout at the top of his lungs. He would say, I am not going to let hospital policy get in the way of patient care. And he would say this like out loud, like all the time.
Exactly.
But ever since then, I loved hematology because for me, that's where I really started to understand all of these cells within your bloodstream. Red blood cells, like your platelets, white blood cells, all of those cells communicate with one another, and you have to understand the way in which they communicate. And you also have to understand the genetics of it to be able to truly understand how to read a CBC, complete blood count, and look at the differential, right? These are tests that we order every day that people just take advantage of, right? They just gloss right over them, right? And it makes me like so mad when like my students or whoever's rotating with me at the time just like glosses over the CBC like it's nothing.
There's a lot of information to really take in a CBC.
What is, when you're looking at a CBC, like what are you looking for? Now you're an oncologist,
Uh-huh.
and you do a lot of general oncology,
I
right?
do general oncology and also a lot of general hematology. And for that reason, I do see a smattering of patients in both fields. And so, generally for hematology, I see a lot of benign hematologists,
Mhm,
hematology things like anemia, neutropenia,
mhm.
low white blood cell count, or platelet issues.
Right.
And so, usually they come to see me either their numbers are too high or their numbers are too low.
Got it.
And so that's why a lot of the patients get referred to me, and then I do an evaluation to sort of see what's going on.
Yeah, so and again, for everybody out there, when we're talking hematology, we're talking about blood cells, right? And we have to remember that within our bones, there's marrow deep within our bones, and the bone marrow is what's responsible for making all of the blood cells. So the bone marrow is kind of like the house for all of the red blood cells and the white blood cells that float around in your bloodstream. And so what happens over time is within your marrow, all of these cells mature and differentiate, right? And as they differentiate, they become different things, right? And so you have your red blood cell, which is your erythrocyte.
Yeah.
You have your platelets, which are really cells that help with coagulation, have some clotting factors and some growth factors associated with them as well.
Hmm.
You've got your white blood cells, you've got many different types of white blood cells. And then you've got, when we say things like hematocrit, really what we're talking about is kind of like
Concentration.
yeah, the
The concentration
concentration
of the red
of
blood
the
cell.
red blood cells in your serum, and it's important
Mhm.
because it looking at your blood and looking at your bloodstream kind of tells us how your bone marrow is doing. Would
Yeah,
you
how
say?
your bone marrow is doing, like what other medical problems you may have. If you have certain vitamin deficiencies or certain infections, can also indicate, hey, look, something might be going on with your immune system. Because the white blood cells usually tells you, hey, look, there's something going on with your immune system, either bacterial or viral, or even allergic reactions can also signify that way. And so, and depending on the different types of the white blood cells, you can actually differentiate, hey, like, is this a bacterial infection? Is this a viral infection? Or if this is more of a allergic reaction that's going on.
So if somebody were to ask you what's in your blood, what do you tell them? So like when your patient says, I know I'm sent to you because I got abnormal blood, doc, like what do you say? Like how do you
Yeah.
explain what
So
blood
I tell
is?
that's a very loaded question,
Yeah.
but obviously we always have to look at, hey, what's going on with your blood cells? And
Yeah.
so the main majority of parts that I look at is usually, do you have a white blood cell problem, or more of a red blood cell hemoglobin sort of problem, or like a platelet kind of problem? And I sort of differentiate. And then obviously there's like a clotting or bleeding issue, and so that's more of a coagulation problem. So I usually differentiate that and put it in the category in that way. And then that sort of gives me an idea, hey, look, which route should I go under? Like, how should I treat this? How should I go after it? And sort of go from there.
Yeah, so you've got your white blood cells, your red blood cells, your platelets, and then you've got your proteins, right?
Yeah.
So you've got your plasma layer. So
Yeah.
you've got all these things that
Exactly.
consist of your blood. What your body is doing and what your heart is doing is it's pumping all of these different cells and all of these different molecules around your body. That's what your circulatory system is. It's just your heart pumping the blood around your body up to the brain, back to itself, and then to the rest of the body. When you think about these blood disorders,
Hmm.
and specifically you wanted to talk about benign hematology,
Exactly.
we know benign means non-life threatening,
Hmm.
right? But when you say benign hematology, what are the 5 common disorders that we're referring to, that we're talking
So
about?
most commonly iron deficiency anemia.
Okay,
So
iron deficiency anemia,
yeah, and then other issues maybe like ITP, it's platelet issues. So if you want it,
idiopathic
yeah, idiopathic,
thrombocytopenia.
and then neutropenia are the more common ones that I see patients for. And then in general, there's like other differentiating like B12 deficiency anemia too, but then that's still under classification of anemia. And anemia of chronic disease or chronic inflammation, because usually anemia of chronic disease is sort of differentiated between anemia of chronic inflammation and then anemia of renal disease.
Mhm.
And so, because one of them is actually related to inflammation, so your body sort of stores away the iron, so we can't use it. So it's not a matter of you needing more iron. It's just your body stores it away because your body's in a state of chronic inflammation. Anemia of renal disease is more related to where your body has enough iron, but it doesn't have that enzyme called EPO to be produced. Basically, because the EPO is made in the kidneys, and so if you have kidney disease, your kidney function has gone low. What happens is the EPO the production goes low. EPO is a signal that says to the bone marrow that, hey, look, I need more red blood cells, and so our solution is to give them a protein called ESA, so erythro-stimulating agent,
Yeah.
to produce more red blood cells because that signal is lost.
Right. So basically, as we were saying earlier, within your bone marrow, you've got all these different types of red blood cells that are being made and evolving in your bone marrow. And so over the course of time, because red blood cells last about 120 days within your system, those red blood cells are going to die off if you don't make the molecule, right? If you don't make the phone call, if the bone marrow doesn't get the phone call of, hey, we need some more blood. Like if I'm calling the bone marrow and I'm like, hey, bro, I need some more erythrocytes. Like my guys are dying off. Like it's time to get some more. If you don't have EPO, you can't make that phone call, right? So that line is disconnected. So you can't make that phone call. And if you can't make that phone call, you're not going to have any erythrocytes in there. Now, what we didn't mention, and again, some of these things, people know, I don't know if people know or not, but erythrocytes, red blood cells, the whole point of them being alive is to have a molecule that we call hemoglobin, which basically takes oxygen from when we take a deep breath of air in, takes oxygen gets stored in the erythrocyte and on the hemoglobin, and it gets delivered to your organs, right? And again, we take advantage of this every day, but the reason why you breathe is to take oxygen from the air, put it in your bloodstream, put it on your hemoglobin, so that way it can be the final electron acceptor in the electron transport chain that makes ATP. It gives you energy to be yourself. So every cell, every organ needs oxygen to do that, to be able to be alive, right? And so that's the whole point of the circulatory system, is to deliver oxygen to the different cells and to the different organs. That's how the body works. And that's what red blood cells actually do, is they deliver that oxygen, right? And what Joomee is talking about, or Dr. Shim is actually talking about in terms of benign hematology, when she says anemia, she means a low red blood cell count. So they don't have the numbers. So either you're bleeding and you're losing a bunch of blood, or your bone marrow doesn't have the line to be able to respond to something, right? So you're not making
Enough.
red blood cells,
Exactly.
right? And this is what you have to differentiate all day. Now, it's easy to know really if somebody's bleeding, right? Either their stool is black or, quite frankly, they're just bleeding out in front of you, right? And that's a problem, because if you can't carry oxygen to the organs start to die off. And that's what I see in the intensive care unit all the time, right? Is I see organs starting to die off, and that's a problem, right? Multi-organ failure, people die from that. That's what can happen.
We want to see them before.
I want to see them before that happens, and so do you, right? You want to be able to diagnose that. So
Exactly.
when you're looking at the different anemias, and it's interesting because you mentioned anemia of inflammation, right? Or anemia of chronic disease, either secondary to kidney or secondary to inflammation. So you guys have all heard of bacteria, you've all heard of fungi, you've heard of viruses. There are a lot of bacteria that rely on iron to be able to grow. They need iron. It's like a growth factor. It's like a vitamin that they need to be able to survive. And so what the body has evolved to do is, when you're inflamed, in other words, if you're infected with something, you develop inflammation. What the body does is it tries to not let the bacteria see the iron, so it lowers your iron level in your bloodstream. That's what it wants to do. But with persistent inflammation, this is constantly low. And if it's constantly low, then this can lead to
Anemia of
chronic disease, or anemia of inflammation. And so it's like the body is supposed to do it, but it ain't supposed to do it too much. It's like when you are a parent and your kid is growing up and you really, really want your kid to talk, right? You're like, okay, come on, like I need you to talk. I need you to talk. I need you to talk. And then your kid starts talking. And then you're like, actually, I need you to shut up. Like, I need you to be quiet. Like, we're going out to dinner. Like, please, like, STFU, like, you gotta, we got people here. So anyway, but I mean, that's, there's these signals that are constantly taking place. And so it's kind of like a battle, and you want to stay in the balance here. So when you're working up anemia, what are the things that patients are presenting with?
So fatigue is the most common complaint that I get. Shortness of breath, sometimes chest pains are the cardinal signs that we're looking for that's more urgently that needs to be treated. Brittle nail and is also actually one of the other common symptoms that patients have. And just generalized overall low energy is usually the clinical signs that we do see.
Yeah. So because again, when you don't have oxygen, if you can't deliver it, you're not going to have any energy. That's plain and simple. This is really, really easy, right? And so it's easy for her to work it out because she does it every single day of her life. But out of the 1.6 billion people worldwide that have anemia, What are the most common causes of anemia in your clinical practice?
Iron deficiency
Iron
anemia, yeah.
deficiency.
Yeah, because even if it's blood loss related to it, it's usually related to iron
Mhm.
deficiency anemia, and so, people who are menstruating a little bit too much or their cycles are a little bit off, I see a lot of patients for that reason, or they went through recent surgery and then they get their blood numbers checked, and so iron deficiency anemia is very, very common.
And then how do you treat it?
And so, there's a couple ways to really go about doing this. So obviously, we try to supplement them with dietary intake of iron, and so we just tell them, "Hey, look, red meat, things that have high iron content in food is a paramount stay." Because obviously, I don't want to be giving people pills,
Mhm.
but some people may need it, and so those are iron pills that they have, and usually it's a lot of over the counter stuff. And so the one side effect related to iron is that it can cause constipation, GI upset. So I have a lot of patients complain about that. You just got to try different formulations of iron that's going to agree with you. Worst case scenario, if you say, "Hey, look, doc, these iron pills don't agree with me. I'm having a lot of GI upset. I'm having a lot of constipation issues. I can't take it at all, or I forget to take them." I'm like, "Okay, we'll come in and give you an iron infusion through the IV."
So that's when I was gonna ask you that. So the time you do IV is you're just like, "Dude, the patient can't tolerate it. Like,
Yeah,
we gotta do it this way."
exactly. Or if their numbers are super low, and then I'm
What's
like,
that cutoff? What's that number for you where you're like, "Dude, I need to give you IV iron first?"
well, usually if the hemoglobin's like 8 or 7, I'm just like, "Oh, absolutely, I would send you to for an IV iron infusions."
Mhm.
I mean, ideally, I would send them to the hospital because if they're that low, then I'm, like, a little bit concerned, but I have some patients that I'm like, "Absolutely not, they won't go to the hospital," and so and so I'm like, "Come into clinic tomorrow, we'll get you the IV iron
Yeah.
infusions, we need to get your numbers building up." But a lot of the times, a lot of these iron deficiency anemia patients, it's more of a slow overall very slow, loss. Because usually the ones that are from 14 to 7, the hemoglobin of 14 to 7, that it's very noticeable because you lost half of your blood volume.
Right.
But the ones that are 7 and they walk into my clinic, they're like, "Doc, I've been always feeling a little bit tired, fatigued, short of breath, something's not right," but they're still functional. And so for them, it's more like a slow bleed. And so for those patients, I'm like, we need to obviously we need to figure out the cause of where they're bleeding from. And so that's why I would send them to GI to do workup, do the colonoscopy or whatnot to sort of see if there's any other etiology of bleeding, but also replacing their iron storage and making sure that they have enough to build more red blood cells.
Now, one of the things that I see frequently, just because my clinical practice, and I haven't told you this yet, is autoimmune lung disease. Like I
Mhm.
see all the autoimmune lung disease pretty much in Orange County, but I see a lot of autoimmune hemolytic anemia.
Yeah.
What is autoimmune hemolytic anemia for everybody?
So basically, it's your own body attacking your red blood cells.
Mhm.
And so what happens is you have more certain breakdown of the red blood cells. Either it's triggered by viral, it's triggered by certain like sometimes medication or viral illnesses,
Mhm.
and that can cause your numbers to go down low. And so it's more of an autoimmune disorder. And so usually the patients come in, they produce the correct amount of red blood cells. It's just they're being broken down externally, and so your body's attacking them. And so we usually have to stop the immune mediated response with steroids and whatnot. So and sort of monitor them and making sure that their immune mediated response is sort of dampened.
Yeah, so when you guys look at cells, right? And you guys have heard me say this before, like cells have certain characteristics. They have certain receptors on their cell membrane. They have certain things in the way that they appear. Occasionally or sometimes, right, depending on medications that you're on, depending on autoimmune diseases that you may or may not have,
Mm-hmm.
your body can generate antibodies that actually bind to the red blood cell. I think in some situations, it's most commonly something I or something on the red blood
Mm-hmm.
cell. There's an antigen on the red blood cell that's named I,
Mm-hmm.
and the antibodies will bind to that, activate a response that actually targets them. So then they get tagged with complement, which
Mm-hmm.
I call the Nerf ball system of the of the blood.
Mm-hmm.
So there's this system called the complement system. Complement is designed to protect us from pathogen. It's been designed. There's like a Nerf ball gun. Remember the old Nerf ball gun? So they would just you would fire that Nerf ball gun and hit somebody. Complement's kind of the same way. You just C3b or C3d just gets targeted onto certain membranes. And when it gets targeted onto certain membranes, it gets marked for the macrophages to eat it. And so as the red blood cell passes through the spleen, it gets
Mm-hmm.
eaten, right? And it just goes away. Like it's hemolytic, like it bursts, it gets eaten, it's gone. And that's a real problem that you see in autoimmune disease. sometimes lymphoproliferative disorders,
Mhm.
some white blood cell cancers and such. And that's something that I see pretty common, right? And there's warm autoimmune hemolytic anemia, there's cold.
Yeah.
Now, one of the things about cold that I actually I guess I reminded myself as I was preparing for this
Uh-huh.
is that to treat autoimmune disease, most of the time we use corticosteroids
Serious,
first,
yeah.
right? To calm down that inflammatory response, to get the white blood cells to just shut up, right? Relax, calm down. But for cold autoimmune hemolytic anemia, you're not supposed to use
Yeah.
corticosteroids.
Yeah.
You're supposed to go immediately to rituximab
Yeah.
or
Rituxan. Yeah.
something like
Yeah.
that, right? So it's really interesting just to remind
Yeah.
myself of that. So as I take my longitudinal assessment for internal medicine, like when I get that question,
Exactly.
I'll get it right, right?
Yeah.
Because that's one of the things that
Yeah, 'cause
differentiates it.
Rituxan is usually pretty good for most autoimmune diseases, and
Yeah.
so even for ITP, I sometimes use Rituxan if I have a patient that's really stubborn ITP, which is this. It's like the same concept as autoimmune hemolytic ITP is where you see it in platelets issues, and so for that reason, we do use a lot of monoclonal antibody, which is Rituxan is the most common one that we use, and so.
Now, yeah, tell me more about ICP. I remember, and again, I didn't go into details before this. I remember there's like a fast and there's a slow or something. Is that right with idiopathic thrombocytopenia? Am I tripping?
Platelet issues, there's either ITP, TTP, HUS, and
Hmm.
so TTPs are the ones that we always worry about where that's a mnemonic of
Hmm.
the fat RN.
Yeah, yeah,
And
yeah.
so fever, anemia, thrombocytopenia, renal disease, and neurological disorder, and
Yeah.
so those are the ones that we always worry about. So TTP is actually a medical emergency from a hematology standpoint of view, and so patients need to be treated with plasmapheresis. So basically, pretty much clean out the plasma and to really get rid of that culprit and treat the TTP. And so that's more of a medical emergency for us, but it's very rare. But it does happen, and so but that's why we look at the clinical signs, and we also look for the thrombocytopenia, and then there's HIT too, so which is another.
Oh, that's what I was thinking
Yeah,
of. That's where I was
yeah,
wrong. Yeah,
yeah,
heparin-induced
yeah,
thrombocytopenia. That's what I was thinking. That's the
induced,
fast and
yeah, the
slow
fast
one.
and slow one.
That's the
Yeah,
fast and slow one.
ITP is usually like more chronic, and so some patients they only have one episode and then it doesn't happen again, and then there's certain patients that have one every like once or twice a year, and so they come and see me and they sort of have a feeling where their platelet numbers are low, and so they have petechiae. So usually patients have like spots on their lower extremities, or they feel like an aura that something might be going on, and then you check their numbers, and unfortunately they're like in the double digits or even the single digits. And so, and then that means I have to treat them more urgently.
So we mentioned what erythrocytes or red blood cells actually do carrying oxygen. We've been talking about platelets. ITP stands for idiopathic thrombocytopenia, meaning you don't know why, but their platelet count is low, right? Thrombocytopenia means low platelet count. And so platelets, remember, are responsible for immediately clogging the bloodstream if there's a leak somewhere, right? So if there's a hole in your blood vessels, platelets glow and clog that out, right? Platelets keep the blood flow going so it doesn't leak anywhere. That's what they're supposed to do. They adhese to the endothelium and kind of block the blood from going elsewhere and staying within the system and getting delivered like it should be. When you have a low platelet count, typically speaking, the normal number is 150,000 to like 400,000. So when your number gets lower than 150,000, we don't really start tripping until it gets lower than like, I don't know, 80,000, 50,000 or so because of the increase in risk of spontaneous hemorrhage
Yeah.
that you can develop, right? And
Yeah.
petechiae, what she's talking about, is actually a physical finding on the skin that actually is a little bit of a hemorrhage, of
Yeah, yeah, a little
spontaneous hemorrhage.
spontaneous. And usually I see those patients like in the 20s. So usually once numbers get down that low, obviously I'm a hematologist and I'm
Yeah,
seeing platelets be zero.
yeah.
So, but we don't want it to be that rate because if it's in the single digits, your risk of spontaneous hemorrhage goes up dramatically. And so for those patients, I would definitely, hey, we need to treat. So usually around 20-ish or whatnot, I'm like, oh, we need to start you on some drugs to really make sure the platelets come back up again and
Yeah,
sort of
or just
figure out.
give platelets if you're
Yeah,
worried about
exactly,
bleeding, right?
exactly. So
Which I
platelet
do all the
transfusion.
time. So the way that to think about this, you guys, is like if you are driving on the road, right? If you're on a 2-lane road and you're leaving your house and you're on 2-lane road and you can see where the lanes are outlined, right? So you got 2 lanes, you know there's 2 lanes because there's a white line in between the lanes, right? You've got one lane on the left, one lane on the right. You can see the white line. So platelets are kind of like that white line, right? And so they're keeping the blood flowing. They're keeping the cars moving forward. If you remove that white line and you don't know if there's two lanes or not, cars can go all over the place, right? And so like cars will run into other cars, things like that. Like you've lost the ability for order. It's kind of like platelets, right? So platelets do that. So like when you lose your platelets, you get a lot of car wrecks, so blood can leak, and that's an issue. That's how I thought about it when I was growing up in medicine and reading all this stuff. That's kind of the way to think about it. And so again, we talked about anemia. We talked about anemia of chronic renal disease. We talked about anemia of chronic inflammation. We talked about thrombocytopenia.
Iron deficiency.
And we talked about iron deficiency anemia. One of the other common hemoglobinopathies, right? I mean, we can get into there's the thalassemias.
Yeah.
And then there's sickle cell anemia. Why don't we talk about that and get into that a little bit?
Sure.
Yeah.
So sickle cell anemia it's more common in certain genetic predispositions. And so African American patients are more predisposed because it's a more of a genetic related disease. There's sickle cell disease and sickle cell trait. And so basically where sickle cell disease, you actually have mutation in both of the genes. And so it's a glutamic acid, I believe, to valine. And that's why there's a mutation. And so the hemoglobin comes out sort of mutated. And so they don't last as long. And under lower oxygen content, they undergo more stress. And so you can get a sickling formation on the actual slide where you look at the red blood cells. And that can cause issues with symptoms. And so patients complain about pain crisis. It's because their body's under stress. And so there's a lot more sickling of the hemoglobin that you normally do see. And so like pain crisis is one of them that patients can have. Acute chest syndrome is one of them. I'm sure as an ICU doc, you see a fair share of acute chest syndrome. And so, and usually it's more because the hemoglobin is under stress. And so it sort of sickles and it can cause vaso-occlusion and blood vessels. And so.
Yes. So like with sickle cell disease, again, Black people have sickle cell disease. The reason why we have sickle cell disease is because when you look at Africa, actually, there's a disease in Africa that's prominent called malaria. Turns out that when you have sickle cell trait, right, not sickle cell disease, right, but sickle cell trait, when some of your red blood cells look a little bit different, malaria can't infect it as well. It can't polymerize within that red blood cell. So in other words, you won't die from this life-threatening infection in Africa. So a lot of people evolved to have sickle cell trait. That's really where it actually stems from. When you look at sickle cell trait, as a result of the hemoglobin molecule looking a little bit different on that erythrocyte, it changes the shape of the red blood cell. So now these red blood cells, which are sickled, can clump together and they can lyse. And when they lyse, it creates an inflammatory response. They clump together and they cause little vaso-occlusions. So they actually block the arteries that the blood is trying to travel through. When you block the arteries the blood is trying to travel through, what happens? You get infarctions, right? So some tissue dies. Sometimes you can get bone infarctions. You can get pulmonary infarctions.
Yeah, and then spleen infarctions.
Spleen infarctions. When you get spleen infarctions, that organ can die off. The spleen's important, right? It really helps us out immunologically, and it helps us out from a blood cleaning standpoint. So you get all these pipes that get clogged up. And when these pipes get clogged up, it can lead to pain, right? And when you have pain and you have pipes that are clogged up, so you don't have a lot of blood vessels that are working within the lung, and some of the lung dies off and you get an overabundance of bacteria, you get infected. When you have a new radiograph infiltrate, when you have a fever and you have chest pain, we call it acute chest syndrome, right? And so that's what actually happens in these sickle cell patients. Now, the most and I'm just going to be blunt, the thing about sickle cell disease, the thing about sickle cell trait is it is one of, if not the most underfunded disease in terms of research. And there's been lots of discussion on why. Is it because it only affects people that look like me, right? Is that why it's underfunded, right? A lot of people feel that way. But when you look at the development of therapies, it's got like the least amount of developed therapies because it doesn't affect the majority,
Hmm.
which is in this country. That's probably why it's understudied. I hate to get political and have conspiracy, but it's actually true. And so it's a really big problem in medical society because honestly, it's really just a small in sickle cell trait, it's just an amino acid difference, like you
Yeah.
said.
Yeah.
So genes, basically what happens with your chromosomes, right? So your chromosomes make up your body. Your chromosomes are full of genes. Genes get transcripted and translated to proteins, right? So DNA becomes RNA. RNA gets spliced and then it goes through a ribosome and then you start to make proteins. So you got different amino acids stacked on top of one another. It's how your body works. That's what it does. And so what we're talking about for sickle cell is one of those amino acids has changed. Like that's it.
Hmm.
There's another disease that's actually probably, and I think it's less common than sickle cell, but it just affects people that are the majority, cystic fibrosis. And you got tons of therapies for that, right? You've got tons of therapies being developed. It's funded, it's being researched and all of that. So hopefully sickle cell disease will get there. Sickle cell.
Well, there's coming out with new genetic therapy where
Tell
they're
us.
where
Yeah.
they're where they're doing like replacement gene therapies.
Perfect.
And so I have one of my friend's daughters undergoing, and so but she has thalassemia, so
Ah.
it's a little bit different.
Now
But
tell us about
yeah, so
thalassemia.
thalassemia is basically a disorder where it's a genetic disorder also, and so where your cells come out smaller, and so for that reason, those patients they can develop anemia related to alpha thalassemia, and so alpha thalassemia, beta thalassemia. There's two thalassemias that usually are generally seen. Alpha thalassemia you see more in like Vietnamese, Cambodian folks, and all these things. I actually had a whole family of alpha thalassemia. They came in, their grandmother was first diagnosed, and then I ended up testing all the subsequent family
Oh
members.
wow.
And so yeah, so that was pretty interesting because I got to look at the genealogy for the patient. So they were from Cambodia. And then beta thalassemia you see more commonly in Mediterranean folks. It's the same thalassemia, but either the alpha or the beta that globulin chain is abnormal.
Hmm.
And so that's what it is.
Yeah, hemoglobin is composed of like it's a tetramer, and you got two alpha
And two
and you got two beta, right? That's normal
Yeah.
hemoglobin, right? And so what she's saying is in alpha thalassemia, the alpha protein's all messed up, and in beta thalassemia, the beta protein is all messed up. So hemoglobin can't hold on to oxygen as well and do what it's supposed to do in those individuals, right? Now, sometimes it's so messed up when the fetus is there that the fetus just doesn't survive because they can't survive.
Yeah, that's when it's more of a severe enough that
Mhm.
it doesn't survive that anemia. And so most of my patients that I see are trait patients. So usually it's not severe enough, but they do have like baseline anemia. And so for those patients, it's important to really check iron content because a lot of primary docs don't understand that. Hey, look, they just see microcytic because one of the signs when we look at an CBC, we look for MCV, and
Mhm.
so we look at the size of the red blood cells. And so what happens is iron deficiency and thalassemia are both very small. And so usually it's a little bit lower for thalassemia, usually 60 or below.
Oh wow.
And so
Okay.
that's why you can really tell, hey, look. But then from a primary care standpoint, it's a little bit hard to differentiate. And so sometimes they give the patient iron, even though it may be they have enough iron, their red blood cells are just smaller.
And we call that microcytic. So when your red blood cell's small, we say microcytic. When your red blood cell's larger than normal, then MCV is like over 100 or whatever, we call it macrocytic.
Mm-hmm.
Now it's time for What's the Buzz, presented by BuzzRx. Every week, I answer a health-related question from one of our viewers. This week's question, how do you manage ongoing pain or discomfort after sepsis? Discomfort after a hospital admission for sepsis can be common. There's a diagnosis called post-sepsis syndrome, which can develop in 50% of sepsis survivors. Patients can have muscle or joint pain, hair loss, or fatigue, among other types of symptoms. As a result of the cellular damage, mitochondrial damage, and dysfunction, as well as persistent inflammation, this condition can continue. Therapy can be quite broad and include selective serotonin reuptake inhibitors, cognitive behavioral therapy, in addition to physical therapy. Next time you or a relative suffers from sepsis, you may need support once you are discharged. That's the buzz. If you have a question, email us at healthexchangepodcast@gmail.com. Thanks again to BuzzRx. Look up your medications on buzzrx.com or the app to be able to save a lot of money. Thanks for joining. If there are 3 things you want primary care providers to know about this, about the thalassemias and differentiating between iron deficiency and thalassemias, what are those 3 things?
Well, I just want to make sure that you check the iron studies before you start patients on iron pills.
Okay.
Most of the times, they're quite right. It's iron deficiency, but there's once in a while you can run into a thalassemic patient. And so it's important that you check for iron content before you prescribe them. And I think that's pretty much good practice, though,
Yeah.
just to have a baseline. And then if you supplement them, just to see if there's any changes and whatnot.
Because the therapy is drastically different between the thalassemias and iron deficiency
Yeah, and that
anemia, right?
because people with thalassemias can actually run into iron overload problem, and so for that same reason, 'cause sometimes if their anemia is severe enough, they get blood transfusion. And so with sickle cell anemia too, it's important that you check the iron content because a lot of patients with sickle cell anemia, they come in, they get transfusion, they get hydration, they get oxygenation, and they get treated with pain medication for their pain crisis. And for that reason, they get a lot of iron. And so for these patients, we see them as an outpatient. We make sure that their iron, it's not that everybody needs to be on iron reducing agents. It's more they need to make sure they're monitored for the iron content, okay, in their blood and making sure they're appropriately treated if it is over.
Yeah, because a lot of these times, these patients that have iron or that develop iron overload, either because they've had persistent transfusions and such, what can happen is actually pulmonary hypertension, which is elevated pressure on the right side of the heart. When you have elevated pressure on that right side of the heart, that can be fatal. I mean, it's an awful diagnosis to have,
Mhm.
and it's something that's very, very difficult for us to
Mhm.
treat. And by treat, I mean like we're really just supporting you trying to lower that pressure so you don't have symptoms. But as far as mortality, like it's really, really difficult.
Yeah,
It's
and
really,
so
really hard.
yeah.
You've treated a lot of patients. You mentioned that family from Cambodia that had thalassemia. What's the most uplifting patient story you have from an anemia standpoint, whether it was a thalassemia that you caught that you were really proud of, or an iron deficiency anemia patient, or an autoimmune hemolytic anemia patient that you treated really well? And
I
you're
think
just like,
I think benign hematology is rewarding in general just
yeah,
because your patients get better. So I think in that regards, because if you treat iron deficiency anemia, patients come back and be like, "Doc, I feel so great. I can function again. I can do what I need to do," and things like that. And they're like, "Oh, I haven't felt this way in like years." And so it's just rewarding to really see that.
yeah,
And then also ITP patients, it's like they're not running into bleeding problems or autoimmune hemolytic anemia. They're not in the hospital anymore.
yeah.
They're not. And so I think just seeing them as an outpatient, it's more rewarding for benign standpoint of view to really see a lot of these patients. So
When you were in New York and you were training, is there a case that stands out? I mean, is there like, oh man, like I remember this. Like, is there something that stands out to you from a benign hematology standpoint?
I had one very interesting case. This patient with hemophilia
Yeah.
came in.
What's
Uh,
hemophilia?
Hemophilia is a that's a different disorder,
Uh huh.
and so where basically it's more of a clotting issue
Yeah.
problem. Remember, it's more you have your whites, you have your reds, and then you have platelets, and then clotting issues. And
Proteins.
so,
You got
yeah,
different clotting factors that get activated
yeah,
as a result of something that happens to make sure that you don't bleed.
mhm,
So hemophilia is
yeah.
a
More of a bleeding disorder.
right.
Like,
So
it's
you
where
can't clot.
yeah, exactly, and so you don't have the clotting factors to really properly clot. This patient came in, she'd never had any history of it, and so that's why it was so weird
How
because
old?
she was in her 40s.
Uh huh.
And so she was 40s, 50s, but she came in with hemarthrosis.
Uh huh.
And so we never see hemarthrosis. Usually it's like blood in the joints,
Yeah.
because that's quite rare. And so that's one of the indication that, hey, like hemophilia is going on. Because usually if it's bleeding, like platelet issues, you have nose bleeding or
Yeah.
gingival bleeding. Okay, maybe GI bleeding too. But usually with hemarthrosis, it's usually like you just bruise easily and like in the joints, and you really rarely see that. And so, and we checked the coagulation study for her, and her coagulations were quite off. And
Yeah.
so they were markedly elevated. She doesn't have any history of it.
Bleeding.
Hemophilia, yeah,
Yeah.
bleeding issues in the past. And so I sort of knew she had an inhibitor. So she acquired an inhibitor of hemophilia, which is quite rare.
Do
And
you know
so
which clotting factor was
I
inhibited?
think she was 9
9.
from yeah, what I understand.
Wow.
Yeah.
And was it? I mean, was it
So what? So
medicine she took? Was it like
no, it was just she just
just
came
random?
in just
Just
randomly.
random.
Yeah, and she came in with hemarthrosis, and so I did the mixing studies and, did everything. Her APTT was off the chart,
Oh
so,
wow.
yeah, so that's why we
That's
sort of
bleeding time. Yeah. Yeah.
yeah,
Yeah.
So we sort of knew
How did you
that.
treat her?
I think we gave her recombinant factor 7A.
Oh, nice.
Yeah. So we sort of overcome the inhibitors because usually with hemophilia, they're deficient in certain factors.
Yeah.
8 and then 9, usually some more common ones. It is an X-linked recessive genetic disorder because it's on the X chromosome. So you most commonly see it in male patients, but sometimes you can occasionally see it in the female patients. Usually that's quite rare though.
You know, when you think about hemophilia, which is a bleeding disorder, the way I like to think about it is like if you have a faucet on in the kitchen and the sink overflows with water,
Mm-hmm.
but you don't have any towels to put down to dry up the water, right? If you don't have any towels to put down to dry up the water, you have hemophilia. And the way that we treat it is
Given them.
we can't turn the faucet off. So we just turn off the water into the house. Like we just turn off the water in general, just the main water pipe, you just turn off, right? Because you're overcoming it with factor 7.
Yeah,
which you're
that's
going
but
higher
that's
up
because
the
it's an
cascade.
inhibitor though.
Right.
So usually it's when you talk about hemophilia, it's more of a genetic disorder
Yeah.
and replace the usual factors.
Yeah.
So when you do the mixing study, you can actually tell like because you mix a patient's plasma with regular normal plasma, and so if there's a deficiency, it should correct.
Right. And
Yeah.
if it doesn't
It doesn't
correct,
correct,
then
that
you
means you
know
have
it's
an
an inhibitor.
inhibitor. Yeah,
Yeah.
something. Yeah. So
Yeah.
that's how that's quite interesting. So
Yeah. And
not
and
much.
these are all things that like, you're helping people and you can help people. And that's what it seems like. That's what
Yeah,
puts a smile on
especially
your face.
yeah, no, it does. It makes you feel good because at the end of the day, people are walking out
Yeah.
feeling great and whatnot. So
Do you ever do any inpatient work?
I do, but not that commonly. Usually for inpatient, it's more like oncology stuff.
Yeah.
A lot of the times it's DIC or medication induced and whatnot. So
Do you
if
ever
they're in the
say like it's
hospital,
sepsis? That's why.
yeah, I'm like, thank you for the consult.
Yeah, yeah. Thank you for the consult. It's sepsis'
Yeah,
problem.
yeah,
Do your
yeah,
thing.
yeah, exactly.
Yeah, I
So
mean, one of the things that I see a lot as a pulmonary critical care physician is sepsis, right? And sepsis is essentially an overactive inflammatory response due to the presence of something. Most of the time, I guess it could be an infection. So you have these bacteria, right? And you've got sometimes you'll hear people say the word like gram-negative bacteria. So gram-negative bacteria means that their cell wall or whatever doesn't stain for anything. And so gram-negative bacteria, though, house a protein called lipopolysaccharide. Lipopolysaccharide is extremely inflammatory. So when your cells and your capillaries are exposed to it, what it does is it causes a significant inflammatory reaction within your body that leads to a capillary leak syndrome. And then when the capillaries separate from one another, the cells separate from one another, that means kind of the blood and some of the other fluid can leak out. It doesn't stay in the blood vessel anymore. So your blood pressure goes low, right? And we call that shock if you don't respond to fluid. But that's what sepsis is. It's an overactive inflammatory response secondary to the presence of something, bacteria, virus, fungi, whatever, parasite even at some point. And that's what we see a lot. Now, for sepsis, and again, I'm talking about it just because this is what we do every day. For sepsis, we have to diagnose it really, really quickly. And you just kind of assume that somebody has it. If they come in, they have a fever, they have low blood pressure. And what you have to do is you have to give them fluid and give them antibiotics. If you give them antibiotics within the first 6 hours or so, that lowers the mortality, right? That's how you treat sepsis. So that's why it's very important for us to recognize it. And that's why hospitals across America, everybody starts to trip out when the bell rings for sepsis patient in the ED or whatever. That's why people are always treating it because they know you got to give antibiotics within a certain time frame and that kind of thing. So that's why early detection is very, very important from a sepsis standpoint. Now, Joomee is saying like a lot of times when you have sepsis patients and you have this overactive inflammatory response, what can happen is it can alter some of the cell lines within your bloodstream. So your white blood cell count can be really low, less than 4,000, or really high, greater than 12,000. Your platelet count can be really low or really high. And guaranteed, she's getting a phone call if your white blood cell count is really low or really high,
yeah.
and your platelet count
More on the low side.
more on the low side.
Yeah, people tend to a little bit concerned about if it's on the low side. Usually, if it's high, it's usually a correct response. But usually, if they're calling for neutropenia, and so usually because those patients can really crash really fast. I had one patient I was talking to, and then he ended up in the ICU, like
Yeah.
literally, like
In
mid talk. So I'm like, that's why I don't really mess around when I have neutropenic patients with gram-negative sepsis, because those patients can crash really fast. But
I mean, man, when you know what's funny about gram-negative sepsis, it's not funny, but when a patient has gram-negative
yeah,
sepsis, like, you just know, like, you can see it. You're
yeah,
like, "Man, their blood pressure is, like, 60 over 40, and
exactly.
they're kinda still talking to you,"
Yeah,
and you're like, "Geez," and you're just waiting. You're like, "Oh, blood culture is positive for
exactly,
gram-negative rods," right? I mean,
exactly.
that's just how it goes, but it's something that we see really, really frequently. From an oncology standpoint,
Yeah.
what do you do mostly?
I usually give them GCSF,
Oh,
the granular stimulating agents,
yeah.
because usually it's
When the white
yeah,
counts.
when the white counts, because a lot of the times it's uncommon to really see low white blood cell count in the community. Usually it's related to chemotherapy, and
Yeah.
so your bone marrow is pretty much like done. And so what happens is patients, they get chemo. It's usually around week 2,
Mhm.
depending on what kind of chemo they get and what they do, and their numbers go down low. And so, in that time, they're sort of unfortunately they're susceptible to infection, and so that's why it's important. If they have a fever of 100.4, we just tell them to go to the emergency room, just because we're worried about that gram-negative sepsis. Because
Yeah.
when you're neutropenic, when we know that they're that neutropenic, we run this risk of infection. We try to give them medications to sort of prevent that, like proneuprogen and whatnot, to after chemotherapy, 24 hours to 48 hours after treatment, to sort of boost up their numbers. Neulasta is the longer duration one,
Mhm.
versus Neupogen is more of a short duration. So usually give Neupogen in the hospital, Neulasta as an outpatient, where we know, hey, look, they got this chemotherapy drug on this day, their numbers are gonna go down. So 48 hours after chemotherapy, we usually administer 24 to 48 hours after chemotherapy, we usually administer the Neulasta,
Nice.
so they don't run into issues.
There's some myths that we always hear about, right? And so there's things that patients will always ask me or say things to me, and I just want you to tell me myth or like fact.
Mhm.
All right. So anemia is just a female problem.
No, I've seen plenty of male patients come in, unfortunately for anemia, for whether underwent surgery or they actually have hemorrhoidal bleeding. So that's actually pretty common to really see patients with anemia. But unfortunately, even children get anemic, and
Yeah.
so for different types of reasons. But unfortunately, not. It's just you see it commonly in more in females because they do menstruate,
Yeah.
and so for that reason, the sort of people label it towards that. But unfortunately, it is a non-gender
Right.
causing disease, so
And then another myth is like being vegan is bad because you can become anemic easily.
being vegan is can be healthy, okay? But making sure you take the proper, supplements. So B12, iron, because a lot of I actually had a Indian patient because he was vegan and he was deficient in B12, and so as long as you're taking the correct supplements, you should be fine. It's just making sure there are certain things that you find in, no other products. Folate is in, green leafy vegetables, but B12 is actually more meat products, so
Got it.
that's why.
And iron too, more
Iron too, yeah,
products, right?
exactly, exactly. But
Yeah.
you can take spinach, kale, and like nuts to really supplement the iron content in that.
So
So
spinach, kale, and nuts have a
yeah,
lot of iron.
yeah.
Okay. You can't live a normal life with sickle cell anemia.
No, I mean, you can, as long as it's being under control.
Yeah.
Like, you do need to follow up with the hematologist, that's a caveat, and so, the main problem that we do see is patients come into the ER, and so, I think we're sort of jaded in that way, even as a medical student or,
Yeah.
like, and so, we see a lot of those patients that come in, unfortunately, into the ER, and as long as and so the patients, I think we get skewed because those patients that are compliant, taking their medications, we don't see them in the ER.
Right. Right. Exactly. Right. And that's the whole
Exactly,
point. That's the
exactly.
whole point of going to see your doctor
Yes.
first. Right. Is like so you don't end up in the ER
Yeah.
urgent care, right?
Yeah, so as long as
Where you're not gonna get the appropriate
exactly,
specialist care.
yeah, and so, like, and you have to make sure you take the hydroxyurea, taking the Exjade, iron suppressing medication, like iron, getting rid of medications, and things of that nature.
Hemophilia means you can't get cuts or you'll bleed out and die.
Hemophilia just means that you just have to be careful, and
Right.
so there's medications, and so patients who are hemophilic they actually have a hematologist, and so I don't see a lot of hemophilia now in practice, but I did see them a lot in fellowship because they follow by the same hematologist for quite a while.
Oh yeah.
And so they usually know, they'll be like, "Doc, I need refills on my factor medications and whatnot." So usually they'll understand. So
People with blood disorders, oh gosh. People with blood disorders shouldn't get vaccinated.
you should get vaccinated.
Period.
Yeah.
It's nonsense. If your blood test is normal once,
Oh,
you're
no.
fine forever.
No. That's why you get yearly checkups. So unfortunately, it's important to get routine blood work check, and so just to make sure, because anything in life, things can change, and so like even think about your body as a car, and
Yeah.
so you need always maintenance, and so unfortunately, when you get older, I tell my older patients, hey, you need a little bit more maintenance.
That's what you tell them. That's funny.
So and they're like, I know. So
Certain blood disorders, does it affect a patient's quality of life?
It can to a certain degree, just
Yeah.
because they need a blood transfusion, you do need to go to the hospital, you need to go follow up with your doctor and stuff like that and get more frequent blood testing. And so that can affect certain patients. And so I think it's important to take that into factor and be like, and speaking to your oncologist or hematologist, be like, sort of figuring out goals and sort of what you want and sort of figuring out, is this the quality of life and things of that nature. So I think those are very valid questions and very valid points, but also making sure that you work with somebody that puts your priority as needs.
If you're moving
Mhm.
and say you're moving from California to New York and you know you have a blood disorder,
Mhm.
whether it's a thalassemia or a sickle cell anemia, how do you go about, like, what should we get from you to bring with us to where we're going?
Well, the last progress notes all very important, and then the blood work, and then sometimes the electrophoresis or the testing that they did to diagnose you
Yeah.
with like sickle cell anemia, the hemoglobin electrophoresis to
Mhm.
really confirm that, hey, look, that's what you have. Usually, if you go over there, they'll repeat some of the testings that you see for a new hematologist, but at least getting the records to making sure, hey, look, you've been seeing a doctor regularly, you've been on these drugs. What drugs have you taken in the past? What has worked for you? Because I think those are all valid, important questions that need to be addressed. So
Joomee, I really appreciate talking about benign hematology.
yeah, no.
I don't know if I told you this. I did tell you about Dr. McFarland,
Mhm.
but there was another doc, Dr. Mohammed Milham,
Mhm.
who was my staff at Iowa. He's a sarcoma melanoma
Yeah,
specialist.
specialist.
And he explained bone marrow to me
Mhm.
and how erythrocytes developed and how granulocytes developed and all of that. And like, that's when I got the most fascinated with it. And like, I saw a condition, and I don't think you would call this a benign hematologic condition, but it is a hematologic condition. I saw hemophagocytic lymphohistiocytosis 3 times in turn year.
That is
And
quite rare. It's
extremely,
extremely rare.
right?
Yeah.
And hemophagocytic lymphohistiocytosis, for you guys that don't know, it's when like macrophages eat up all your erythrocytes. They eat up like all of your red blood cells within your bone marrow. So when you biopsy the bone marrow and you look under a microscope,
It's all macrophages.
you see this big like megakaryocyte or whatever, this macrophage is like eating up all of your erythroid lineage. It's life-threatening, right? So it's not benign because these kids don't make any blood cells anymore, or they are trying to make blood cells, but the macrophages keep eating them shits, and it's like bad, right? And I saw it like 3 different times, and the kids were like 28, like 19. It was crazy. And the immunology that I learned and what we did for those kids is what kind of motivated me to really pay attention to cell communication and understand the products, how things work, how your body works. What we typically like to do towards the end of an episode is we like to talk about positive things within a physician's or whoever's the guest's life that have led them to where they are right now. So for you, do you have any positive pulses, whether it's a patient that you treated really well? What is it that is a positive pulse for you?
A lot of benign hematology is nice in that you can actually see the results and you can see patients get better. Unfortunately, I can't say the same always for oncology. And so I think benign hematology is a little bit nice in that you treat patients, they come back, they feel better, their disease is under control for the most part, and they're able to functioning fine. So I think that's the most rewarding part. A lot of these diseases, for a lot of benign hematology issues, because it is something that needs to be dealt with but can be treated.
Yeah.
And I think that's a key point in all this. It's like, go see your doctor. It's gonna be okay. We'll get through it. You know what I mean? So I think that's a key point in sort of all this, and it's pretty rewarding to really see patients more of a routine basis and having not a pleasant conversation.
Right.
So we're talking about the other alternative for oncology side.
So this morning I got up to study at 4 a.m. and I subscribe to like 5 different medical journals. So,
Oh, wow.
The American Thoracic Society Journal, Blue Journal, New England Journal of Medicine, Nature Reviews Rheumatology, Nature Reviews Immunology, and then the Nature Reviews like primers, disease primers. Those are the 5 journals that I read pretty much every month. And about 2 weeks ago, I had a 62-year-old male patient present to me for incidental findings seen on an x-ray. Had increased interstitial findings, right? Asymptomatic. Got a chest CT. Chest CT showed some bronchiectasis, some centrilobular micronodules, and some perilymphatic nodules. And they're kind of all throughout. And so when you see a CT like that, and he had lymphadenopathy. So you see a CT like that, you're like, oh my gosh, is this cancer? Oh my God, what is this? So on the CT scan, you could actually see like increased like whiteness in the lymph nodes, which represents calcium deposition. So I took the patient to the procedure suite and did a bronchoscopy, biopsied the lymph nodes, biopsied the lung. And it was all just inflammatory stuff.
Good.
Because, exactly, right? Because I was like, this is either sarcoidosis or silicosis. Because the guy is a construction worker. And he's been building houses for the last 50, 60 years. And they don't wear masks and they inhale all that stuff. But this morning, I grabbed the Nature Review Rheumatology. And on the cover is environmental exposures that lead to rheumatoid arthritis, sarcoidosis, like silicosis. And I go to page like 137. That's what the page was. And I start reading the article, and it is exactly what I saw. And so for me, as like a nerd, I guess, that's always like reading and such, it's just one of those things where it's like, luck is when, preparation meets like opportunity. And it's like one of those things where this, you prepared for this, you knew what to do, and then you look on this magazine and it's like published right in front of you. And it was just one of the really cool experiences of at least my life for this morning. So I think, just like you said, finding reward in things that you participate in every day is wonderful. And you've done that with your practice, doing that with your family. And it's been a real pleasure to have you today. So
Thank you. Thank you so much for having me.
thank you so much. Thank you guys for watching The Health Exchange. We're on Instagram at The Health Exchange Podcast. Get us wherever you get your podcasts every Thursday morning at 6 a.m. Pacific, 9 a.m. Eastern. Joomee, where can people find you?
Oh, so I'm at USC, but I'm at part of the satellite clinic, and I'm on Winter Park location. If you have any questions regarding hematology or oncology patient issues, then give me a call and we'll get you set up.
If you have anemia, she's wearing red, give her a call. We'll talk to you guys soon. Take care.